Welcome, everybody, to Security Health Plan Academy, our monthly webinar series designed to provide you with information relevant to your health, wellness, and healthcare plan. Just a few quick notes before we get started. Please remain on mute throughout the presentation. There will be time at the end of our session today for questions and answers. You can submit your questions using the chat feature located toward the bottom of your screen. We will be sending everyone here today a follow-up email with links to today's recording, a PDF of the slide deck, as well as responses to questions that have been submitted. Today, we have Marshfield Clinic Health System Service Line Medical Director for Adult Primary Care, Dr. Jennifer Strong, with us to present this month's webinar, The Importance of Having a Primary Care Provider. Dr. Strong will provide an overview of why your relationship with your primary care provider is so important. She will also outline the recommended screenings, provide tips on how to prepare for your provider visits, and make the most of your time with your provider. Dr. Strong has been with the health system for 12 years, where she spent a significant amount of time working with the Institute for Quality, Innovation, and Patient Safety. She transitioned to her current position of Service Line Medical Director last fall. Dr. Strong has practiced medicine in Indiana, North Dakota, and now Wisconsin. She attended medical school in North Dakota and finished her residency in Illinois. So thank you for joining us today, Dr. Strong, and I will turn it over to you.
Thank you. Can everybody hear me okay?
I can on this end, so I think we should be good.
Perfect. I had to do a little bit of microphone switching. So good morning, and thank you for having me here. Again, as the Service Line Medical Director for Adult Primary Care, I oversee about 200 primary care providers over a range of about 49 different clinics in the state of Wisconsin and Michigan. So I'm here today to talk to you a little bit about why it's important to follow up with and establish with a primary care provider. So starting off, we have a lot to talk about. There's a lot of information. Medical knowledge continues to grow exponentially. It was estimated that in 1950, it would take 50 years for medical knowledge to double. In 1980, it was down to 7 years. In 2010, it was down to 3.5 years. And in 2020, it was estimated to take 73 days for medical knowledge to double. So that's really intimidating when you think about how much information there is out there, and it's really difficult to keep up with that as a patient and a person, but also as a provider. So how can we possibly keep up? You know, when we were in med school and residence, they told us that we would have to be lifelong learners, but when we've got information growing that rapidly, it really seems almost impossible. So certainly this is where we can see some of the mismatch between what you may have heard or seen on the news or read on the internet, and then you ask us about it, and we haven't seen that yet. So again, with so much information out there, it's next to impossible for us to be caught up on everything that you may be seeing. We do have a lot of different tools that help us. We have different programs that we go to, sites that are specifically there to look at evidence-based medicine and practices and keep us up to date on things. So we're very fortunate to have those types of tools, but again, it's a huge task. So another big part of our job is to take what is known and apply it to the specific individual. Not every medicine is good for every patient, and that certainly goes for testing as well, including many of the things that we do for screening exams, which we'll talk about more later. So what are some of the benefits of having a primary care provider? U.S. adults with a primary care provider have been shown to have improved health outcomes. Those that had a primary provider had 33% lower healthcare costs and 19% lower odds of dying when compared to those who only saw specialty care. They've also seen decreased cost, reduction in costly hospitalizations and emergency department visits. And a primary care provider is able to care for you throughout your entire life. Family medicine training covers the entire spectrum of life, including obstetrics, and internal medicine, the training is focused on adults. Another benefit is we are able to manage and coordinate care with specialty team members. Again, as our health gets more complicated, we may need numerous providers and specialists to help with that care, and the primary provider is the one that can kind of help pull all those things together and make sure that everything's being looked at kind of from a top-down view to make sure that nothing is getting missed. Also, we are able to help prevent disease with our screenings that we recommend in preventive health, and also keeping you out of the hospital, hopefully. So who is recommending and why? That's kind of a loaded question. There's lots of folks that have ideas and recommendations. We generally try to follow the U.S. Preventive Services Task Force. They continually review the prevention side of medicine and give us recommendations on what we should and shouldn't be doing. I know it often seems like, well, why wouldn't we do everything? But there are some things that a person may have that will never have an effect on their life. And if we find it, we don't know what to do with it. And if we want to do something with it or feel like we need to, we may end up actually causing harm. So it's a little trickier than just do it all. We may end up finding out things that we wouldn't have needed to know, that wouldn't have mattered to us in our lifetime. So how they help us, they give us grades of recommendation. So the things in green, the grade A and grade B things, are things that we should offer and provide for folks and discuss and encourage. Grade C things, we offer and provide for selected folks, depending on individual circumstances. Grade D are services that we will generally discourage. The task force recommends against those services. And there's moderate or high certainty that the service has no benefit or that the harms outweigh that benefit. And then, of course, there has to be a grade I, and that's where we aren't sure. We don't feel like there is enough information to completely recommend or not recommend. So again, that is something that if that service is offered, patients should understand the uncertainty about the balance of the benefits and harms. So here's just, and this is just part of a table that goes through some of those preventive healthcare recommendations. Again, it depends on your age, and so things may be recommended at one part in your life, and then those fall off the recommendation as we age, and vice versa. So here's just a sampling of some of what those grade A and B recommendations are. Again, this list is not all inclusive, but things that we really feel strongly about having good evidence of the benefits include cervical cancer screening, like pap smears, colon cancer screening with colonoscopies, checking blood pressure, which you get generally every time you come to see the provider. Also screening for cholesterol and lipid disorders, and then asking about tobacco use. Grade B recommendations, again, so not quite as strong as A, but still things that we're going to recommend to everyone, is an abdominal aortic aneurysm ultrasound, and that's going to be, again, for a specific group of folks if they've ever smoked. Also wanting to know about folks and their alcohol intake, because certainly that contributes to many other aspects of health. Breast cancer genetic risk, again, for certain individuals, that is something that would be recommended. And then there's a number of different screenings that we do, so not so much tests necessarily, but questions and questionnaires. So I'll go into these things a little bit more. Some of the screening questionnaires, things that you may have asked when you present to the office. The alcohol usage, those again are very standard and important to us because alcohol use certainly has an effect on many aspects of our health. It can increase someone's blood pressure. It can certainly lead to liver issues, et cetera. So it's important for us to know how much of that is there so that we can direct where we are looking and monitoring. Depression screening, again, we generally start with a 2-question process, and then depending on those answers, we may progress to more questions depending on the answers. There are various tools we use to ask about tobacco use and smoking. For women, it's a category B or a rating of B for asking about intimate partner violence. And then again, for folks that have certain risk factors, getting that genetic testing for breast cancer risk. As far as some of the labs that we could do, blood sugar testing and diabetic screening. Again, if someone is overweight between the ages of 40 and 70, we would recommend getting a screening blood sugar. Cholesterol, again, when we do a test, we want to make sure that the answer is going to change something that we do. So if somebody's between the ages of 40 and 75 and they have elevated risk for cardiovascular disease, which includes things like high blood pressure and smoking history and blood sugar, then they may fall into a category where we would recommend cholesterol medication. And so then we want to make sure that we're checking to see if those folks in that age group have high cholesterol. And the CDC recommendation is to screen every 5 years. A lot of the time, folks have high cholesterol, so a lot of times they do end up getting that checked yearly. But again, when we're talking just about screening, it would be every 5 years if everything was normal. Hepatitis C screening has actually been updated. Previously, it was recommended for those that were born between 1945 and 1965, or those at high risk. It's now been recommended for everybody over the age of 18 to have a once-in-a-lifetime hepatitis C screen. And then if there are other risk factors, that should be repeated at other times in life. HIV screening for everyone is again recommended between the ages of 15 and 65. This recommendation, again, is a once-in-a-lifetime sort of test. And there's a wide range of ages there and a lot of things that are going to happen in those years. So if that test has been done and then there's other increased risk factors at another point in life, it's important to recheck that. Also, we can check for hepatitis B and syphilis and tuberculosis. Again, we want to screen those folks that are at high risk. The same with gonorrhea and chlamydia, especially for women under the age of 25, to help maintain their fertility as they get older. And then PSA, or the prostate lab, that one's a little bit more tricky and one that we'll discuss a little bit more as we move on. As far as cancer screenings, there's a number of those. Cervical cancer screening, again, pap smears are recommended regularly up until the age of 65. It kind of depends on what your age is, depending on how often and which test we do. But at age 65, if everything has done okay, currently the recommendations are that we can stop screening. Routine pelvic exams in women that don't have any symptoms of any gynecologic problem is not recommended. And so as we learn more, as healthcare changes, we change our recommendations to match with that. Colorectal cancer screening has recently undergone one of those changes. It used to be starting at age 50, we recommended colon cancer screening, and that's now been changed to age 45. So there's various ways to check for colon cancer. There is a stool study called Cologuard that can be done every 3 years if a person does not have increased risk or a history of an abnormal colonoscopy, or having the full colonoscopy every 10 years for those that are at low risk. There are a couple of other options that we used to use. We don't so much use them anymore, but they are still out there for folks in case there are reasons they can't have a colonoscopy or Cologuard. Breast cancer, again, that's one that can vary depending on who you're asking. If it's the American Cancer Society, if it's the Preventive Service Task Force, if it's the radiology groups, they're all going to vary a little bit on what their recommendation is. So starting at age 40 until 49, it's kind of an individualized plan between the provider and the patient, depending on their family history and what risks they may have. And then determining, do we, start mammograms at 40 and do them annually? Once you get to 50, it's recommended every other year. Again, that's from the Preventive Services Task Force. Some of the other recommending bodies will recommend annually. So again, that may be why you see some variation between yourself and your friend or family member. Again, it's one of those things that we take into account what the patient's wishes are, if they're more comfortable every year, or if every other year is fine, if there's no family history of breast cancer, that sort of thing. Lung cancer screening, again, that is something that has recently changed as well. Anyone between the ages of 50 and 80 with a 20-pack year history of smoking is recommended to have lung cancer screening. It used to be those with a 30-pack year history, and that has now changed to an even lighter amount of smoking history. So again, these things ebb and flow and evolve and change. So something that you hear one year may be different the next. And again, going back to how much our information changes each year can help to explain that. Other things that we do, obviously the blood pressure, like I mentioned earlier, we check the blood pressure at all of your visits, osteoporosis and bone strength. Again, women age 65 and older are recommended to have a bone density scan. Lots of times we end up starting that much earlier for women once they're postmenopausal. If they have an increased fracture risk and concern for osteoporosis, then we can start that screening earlier. Like I mentioned, that abdominal aortic aneurysm. This is a specific one for men age 65 to 75 who have ever smoked in their lifetime. It's a one-time screen. Again, if there's family history or other things, we may do it in some other cases as well. Grade C recommendations, again, these are things that we don't use routinely. The benefit is likely small. And this is where prostate cancer screening comes in. I know a lot of times folks will ask me, well, you're drawing my blood anyways, what's the harm in doing a PSA? And the harm in that could be that you might get prostate cancer at some point in your life, and it may never have an effect on your life. There's many men who will get into their 80s and 90s and die from other things and be found to have prostate cancer on autopsy that would have never and didn't ever have anything, any effect on their life. There are others, though, that will get prostate cancer that will be aggressive and it will spread and it will lead to worsened health and in some folks death. So how do we know the difference? And I think that this is one of those spots where we're learning lots more all the time, but we aren't quite there yet. The prostate lab can be elevated for things other than cancer. So if we get this lab and it's elevated, then that gets us a trip to the urologist and a conversation with the urologist that says, do we want to do a biopsy? And if we do a biopsy and we find cancer, was this going to be one of the ones that was okay? Or was this going to be one of the ones that wasn't okay? And so it just leads to a lot more conversations, which isn't a bad thing. But sometimes folks say, you know what, there's no family history. I'm not concerned with that. I'm okay with not doing it. And others are not. Others want to make sure and check it. So again, this is that probably one of the bigger ones that we lead to a conversation with the patient. Again, why you may see a difference from what happens to you versus your friend or family when they see their provider. Those things that have grade D recommendations, so these things are recommended against, they likely harm or have no benefit. It's really interesting in medicine, it's sometimes hard for us to stop things that we've always done, but self-breast exams, they've actually been recommended to not do them. And again, folks may say, well, what's the harm in that? The harm, again, can be that we think we feel something that leads to the person needing additional testing, et cetera, and it's nothing. And it causes undue and unneeded stress, additional testing, et cetera. So they've not found that there is a benefit to those and that there actually may be some harm. There's various other things there. You'll see carotid artery stenosis screening. And again, those are some of those things that you can get offered at some of those lifeline type screenings. Again, we tend to check things in medicine that we can make a difference for you. We don't want to just be doing testing to test. So if someone does have carotid artery stenosis, we're not going to recommend having pretty significant and risky surgery unless they're having symptoms. And so if we just went and screened everyone, we may find a lot of results that we don't need, that aren't going to add to the person's overall health. But if someone did start to have symptoms, then we would look for it. So again, it can be a little bit counterintuitive at times, but again, our main goal is to first do no harm. So that can sometimes be a tricky balance. And then there's a whole lot of things that have that grade I, which is we're not sure. So, lots of things on here. Again, this is where clinical breast exams come in, coming into the office and having a provider do a breast exam, especially if those folks are being screened with mammogram, checking for thyroid disease without symptoms. Again, not necessarily recommended or helpful. Doing screenings for bladder cancer, oral cancer, skin cancer. Again, that all depends on your personal history and your family history at times. So that's why it's really important to talk about those things with your provider so that it can be personalized to you and your risks. As far as challenges for us in primary care, everyone's health is different as we age. So sometimes we may discuss continuing screening if someone is very healthy and we feel like their life expectancy is such that we would recommend continuing to screen for something, even if the recommendation had said to that it was okay to stop. There can be the opposite, where we may decide that we want to stop earlier if there are other significant health issues for a person. One of the biggest challenges that we're going to have in the United States with healthcare is that there are projections that the United States could see a shortage of up to 48,000 primary care providers by 2034. That's not that far off. And with a growing and aging population, this will put significant pressure on our nation to increase the supply of PCPs. One of the biggest issues with that is you can't just go to the store and buy one. It takes, at least an 8-year lead time, and then adding residency onto that, 11 years to get a primary care provider. So certainly something that is coming, and we all need to be aware of. So it's going to be important to have a primary care provider, but it's also important to realize that there's going to be a shortage, and we're going to have to all work as a team. So your particular provider may not be available, but we may need you to get in with their team member to be seen. A couple of other interesting things when you compare the US to other industrialized nations. On average, the US spends half the amount as other nations on primary care. Some states in the United States have passed legislation to measure spending on primary care, and some have set targets to increase this spending. The reason for that is that if there is that higher amount of devotion to primary care, they have seen 14% decline in healthcare expenditures, so not having to spend as much money. And they've seen a 3.4%, 14% decline in healthcare expenditures after increased primary care spending over a 4-year period. So they put more money into primary care, and they saw a decline in how much they were having to pay out for folks being hospitalized and having significant medical problems. So there really is some evidence there that the more we put into primary care, the better and healthier our population is, and how that can be a savings down the road. So when coming in and getting ready for that visit, we want to first make sure that you understand your insurance. That varies widely. Some things are covered under some policies and not under others, and we have no way to gauge or know that. So it's really important for you to understand your coverage when you come in. Always important to ask questions about recommendations. As you could see as I was going through that, it really can be personalized, and I may recommend one thing for one person and something else for someone else based on their personal history. Always come prepared to ask questions. It's also okay to decline anything that we recommend. It's my job to tell you what the recommendations are, and I want to make sure that you're making informed decisions. So don't feel bad about declining anything, but just make sure that you have the conversation and understand what you're declining and why. And then also keeping in mind that we need different things at different stages of life. So sometimes we need to be seeing providers every couple of years. Sometimes as we get older, we need to be seeing them every year. And then depending on our health, we may need to be seen every 3 months or every 6 months, depending on our medical difficulties. So it's a lot of information in a short amount of time. I did want to try to make sure and leave some time for questions if folks had any. So please, if there are, please put them in the chat, and we'll see if anything has come through with that. Certainly, thank you for letting me share this with you today.
Well, thank you so much, Dr. Strong. That was super informative. I do have a couple questions if you have a few minutes.
Yeah.
The first question I had received is, if I am seeing a few different specialists and have a question about my care, should I start with my primary care provider?
So that's where it can get interesting. I would say, I think that it's fair to start with your primary care provider. Again, assuming that you're in the same health system. So again, that's why it's important to kind of have a medical home where you have your primary provider and the specialists that you see, so that we can all see the same information. But if that's the case, your primary can look at the notes from the specialist, and then if they're able to answer the question, because sometimes it's just you may want something or need something re-explained. from your visit with the specialist. And so we can look at that, see if it's something that we can answer. And if it's not, then we can reach out to the specialty provider. So I think the primary provider is always a great place to start, but just realizing that we may need to reach out to the specialist to get further clarification if it's something that we don't know.
Okay. Does my primary care provider know when I make changes in my medications with a specialist? Are they updated with that information, or do I need to call them and let them know?
That's a pretty tricky question. So what I can say is that an average primary care provider that's working full-time has 2,000 patients in their panel. So that's a lot of folks to be watching over. When you go to see a specialist, they do generally send us that note for us to review. Sometimes, depending on if it's a really big issue, that specialist may reach out to us as well. But I do think that if there's big changes that are happening with your specialty care, that it certainly is reasonable to send a little email or a call in to your primary just to say, hey, I saw my specialist, they made these changes, I just wanted to make you aware. It certainly doesn't hurt. And, again, the primary may get those notes, and most time do get those notes to know that. But certainly, communication systems can fail, and especially if you're outside the system too, we may not get that communication. So if you feel like it's, a pretty significant change that you want to update, I would say I'd always err on the side of caution and reach out.
All right. Some that have come through via the chat, is there a difference between an annual wellness check and and a preventive physical exam?
Yes, so again, that is going to depend on your age and your insurance. So younger than age 65 and not on Medicare, those are going to be kind of your annual physical, your preventive visit. Once you turn 65, that's when Medicare covers the annual wellness visit, which is kind of a visit that goes through many risks. That's where they're asking you questions about throw rugs and falling and safety questions at home, those sorts of things. And so that's the part that Medicare covers once a year. Now, if folks don't have any chronic medical problems, there's not a whole lot to that exam, and it doesn't even really include a physical exam where someone, is listening to your heart and lungs. But a lot of times providers will do a physical exam at the same time. It can be a point of confusion sometimes, because when people were, say, 64 and they had their complete physical, they kind of had, one type of exam. And then when they're 65, they have their annual wellness visit, and it may not seem the same anymore. And again, that kind of depends and changes based on ages and what's recommended for screening, et cetera. So they are different. And that annual wellness visit, if folks do have other medical conditions, usually is paired with what we would refer to as a problem visit, or a time when we would address your diabetes or high blood pressure or high cholesterol. Sometimes those things can kind of happen in the same visit. Sometimes they're separated out. So it is kind of a complicated question and answer, but it is something that you can certainly chat with your primary about, but Medicare does cover that annual wellness visit at age 65 or when you go on to Medicare.
Great. And I think we had a webinar on that one last year, the differences between those two exams. So I can't remember who submitted that, but that might be something you can look at, or we'll include that information in the follow-up meeting.
That would be great, because it is a complex thing that took me a long time to wrap my head around when I first was in practice.
I will include that link in the follow-up email if you want to watch that, or if you go to the Security Health Plan Academy landing page website, the link to that recording is on there as well.
Great.
Perfect.
And then I think if we can try to answer that one last question that was submitted, and then we will dismiss, but this is, I think, is a good one. How do you pick a primary care provider? I've never met mine. My original primary care provider left the system, and you just kind of get a picture and a paragraph.
It can be really difficult. And sometimes that first time you meet them, you're like, this isn't the best fit. And certainly it sometimes just comes down to trying it out, going in, meeting the provider, seeing if you feel comfortable. Certainly we want to make sure as providers that our patients feel comfortable, because if you don't, then we know that you won't share as openly with us, and then we aren't able to help you if you're feeling reservation at all. So we want to make sure that relationship feels like you are happy with it, because if it's not, we don't take offense to you saying, you know what, I think I'm going to find a different provider. We would much rather that than you stick it out with somebody that you're not comfortable with. So you're right, there isn't a lot to go on other than a picture and a paragraph, but I would encourage getting in with the provider, sitting down, having a conversation, seeing them, and then deciding at that point. But you're right, it's really hard without meeting them.
Well, thank you so much again, Dr. Strong. I thought this was a really nice, informative presentation about primary care. And I think with that, we will go ahead and close this out.
Excellent. Well, thanks so much for having me.
Thank you. Be well, everyone.
Okay. Bye-bye.